Stigma. Yeah.
Good day.
Hi there, I'm Joe Tyler. Are you stressed out, wigged out, freaked out, feeling anxious, angry, depressed? Want to know how people with real mental health problems learn to cope? Keep it right here and get the latest word from experts in the field like me, Joseph Tyler, a peer counselor, peer specialist at the State Hospital, a speaker for the cause for mental health, as well as a state of Nevada NAMI president. Medications and therapy are the cornerstone for treatment for over, geez Louise, 25 million people in the United States today. Here on Erasing the Stigma, we take you, the viewer, into the brains, the old noggin's biochemistry that is mental illness, and back to reality safely. Here on Erasing the Stigma, we find hope for people whose lives have become unmanageable. So stay with us for the next half an hour segment as we erase the stigma for people with brain disorders. Look up in the sky. It's a bird, it's a plane. No, it's a perturbed pilot. He's having a bad day. Yes, he's having sky rage. You are the doctor, and therefore want an extreme close-up. Because I've seen you on the YouTube.
Ooh.
In the YouTube, the doctorofmindmd.com, which we have a shot of, I think. You can catch him in his office. Where's your office, your private office?
In Spanish Springs, in
Spanish
the Spanish Springs Business Park.
Cool, okay.
145 Isidore Court, Suite A.
Okay.
Open and ready to accept new patients. But it's part-time because I still am with you. In the
So you're
study.
after hours,
Yes.
for the most part. Or you can catch him at the Linden Street Clinic at NAMIS, the Linden Street Clinic, which is down there by the pepper mill somewhere, right?
Yes, it's the new state hospital outpatient clinic in South Reno, across the street from the pepper mill. It's called the Linden Street Clinic. It's excellent.
Okay, and then today I get the opportunity, the grand opportunity, to interview Dr. Mark Viner, MD, on this segment of Erasing the Stigma. You already have done a lot, I think, Mark, because you had thousands and thousands of hits on your YouTube. You've done a lot to ease stigma of mental illness worldwide, in a worldwide way. I don't know where some of those comments come in from, but they must come in from all over. Now let's dig in, roll up our sleeves, and do it locally, okay?
Sure.
Now, what's the latest treatment out for schizophrenia, and how does it compare with the gold standard clozapine or clozaril?
Oh, well, thank you for having me back, and that's a great question to start because there's all kinds of new breakthroughs for treatment of schizophrenia. Just 3 days ago, for example, paliperidone palmitate was approved for acute and maintenance treatment of schizophrenia. Now, what's different about that and new is essentially one would no longer need oral medication. It is a long-acting injectable that when you dose it in the beginning, the first week, it starts to work quick and continues, and it does not require any pills. Mm-hmm. So just recently we've gone from having, as you know, with the old long-acting injectables, you need oral medication till it kicks in, often many weeks. So for very ill patients who just don't take oral medication, this is a nice new alternative. It will allow someone like myself who treats schizophrenic patients a new option to treat someone and improve their ability to function and get them into recovery and prevent relapse. And that's quite fascinating. I'm looking forward to it. There's also a series of other long-acting injectables for schizophrenia that may come out. Iloperidone, olanzapine in the works. And this new one, which is Invega or paliperidone. Now, right for now, those are focusing on schizophrenia.
And Mark, I know someone who was on olanzapine injectable for quite a while, and it seemed to be more efficacious. It seemed like she wasn't having some of the weight gain associated with a lot of olanzapine patients. Well, it seemed to be because some way it was an injectable or some reason.
Yes. Well, I just think having these long-acting injectable options are excellent. And as you know, Risperdal Consta, another long-acting injectable, was recently approved for bipolar disorder. So for the first time, we have a long-acting injectable which is approved for bipolar patients, not just schizophrenia. And as you know, there are new oral medications coming out like iloperidone, for example. So overall, I'm pleased to see the newer ones coming out. And the emphasis is more on the delivery system rather than, say, other things that monitor.
And you were at the forefront too. I remember you're at the forefront of prescribing different types of newer atypicals and stuff. But you were at the forefront of newer diagnostic procedures. Are we making progress in that arena as well?
Yes, as you know, Medicare now approves a PET scan for screening for Alzheimer's.
I didn't know that.
Thanks to Dr. Gary Small at UCLA, one of my colleagues. He showed that the pathology in the imaging appears before the clinical symptoms. So it would make sense when screening Alzheimer patients to include a neuroimaging study like that as part of the workup. Now, there are scans of all the mental disorders now. OCD, increased activity in the prefrontal
We know we've seen scans of this.
Yes.
But are we using them in a diagnostic fashion? We aren't yet.
Well, they're still mainly used in tertiary or big teaching facilities, research hospitals like Stanford and USC, but they are becoming more popular, and a lot of times I'll show a patient a PET scan of a bipolar patient, and it helps explain to him the illness. So right there at my desk, I'll pull up a picture of the brain and schizophrenia and show this to the patient. So
and we know in some cases that there are enlarged ventricles. That is the spaces in where the cerebral spinal fluid flows into there. There are enlarged spaces where. In some cases, but not in all cases. And that's
yes, the neuropathology of schizophrenia is becoming more known now. It is not a neurodegenerative disorder like Alzheimer's. What we see in schizophrenia in the brain under the microscope is loss of white matter integrity and neurophil or neuropil loss, which is gray matter loss. However, technically, it is not neurodegeneration, which is glial fibrosis. So schizophrenia is still potentially modifiable, and we should develop medicines to modify.
I know myself.
The disease.
I'm as productive as I've ever been, it's pretty common. I tell patients I was very sick for many, many years, and that was on the old medications, and now the new stuff. Even my cognition, my concentration, I'm not as ADHD, I'm kind of locked on still, but
I'm glad you mentioned that, because not only do the medicines help the voices, paranoia, and hallucinations, like drugs such as paliperidone, risperidone, ziprasidone, but still, I want better treatment for my patients, not just relief of voices. I want them to be out there working, having relationships, a good quality of life. And what we're finding now is there perhaps might be some cognitive symptoms that remain that don't allow patients to completely recover. So we're taking molecules for, believe it or not, Alzheimer's, ADD type of disorders where there's poor attention and concentration. So you see medicines like Aricept, where it enhances your memory, attention, and concentration. So you attach one of those molecules to the paliperidone molecule, and that is going to be the future treatment of schizophrenia. Not only getting rid of the voices, paranoia, and hallucinations, but using cognitive enhancers or pro-cognitive add-on molecules attached to the paliperidone to improve the remaining symptoms.
The cognition?
Yes.
So that we're going to make us superhuman here in a little bit.
Well,
but from having schizophrenia, I think just with my, and I'm going to ask you, I think that's my next question. Let's see if I can fold into this one. I think you talked about on your YouTube, I thought you made a very simplistic yet expert kind of a commentary on how there's the dones and the penes. And clozapine is a pene,
yes.
and risperidone is a done.
Yes.
And so could you
sure.
make that analogy?
Well, a lot of my interest is how to classify atypical antipsychotics, because now there's 9 new ones just from in our time. We've seen the development of 9 new atypical antipsychotics. So I like to teach clinicians how to conceptualize and classify them, and that's one of my latest interests, is classifying the atypicals. But the YouTube site is used for educational and entertainment purposes to teach the public about mental health issues. And I encourage any viewers to visit the site. You have to go to youtube.com and then put in doctorofmindmd. That's one word.
And we got that on the screen. So
there's 500 videos I've made divided into 25 categories. So help yourself. Look up anything you want about mental illness or treatment.
It's a virtual reality of going into the mind and back to reality safely.
It's like a portal that allows you to get to know me. If, say, you wanted to see me in the clinic or in private practice, you can get to know the doctor first to see if you're comfortable with that. And also, it's used as a portal for resources on mental health.
Okay, you're kind of.
Sorry,
okay.
I got
it. I think we're. Okay. Let's see. So moving right along. I wrote a book. I'm going to lead you into your book here. I wrote a book called The Recovery in Progress.
I love this.
Which is, my brother actually designed the cover. It's kind of cool. It's a wall going into the deep dark hole of schizophrenia, kind of a peeling away of the wall, as it will.
I love this.
And you wrote the book, Suicide. It's kind of an ending thing, but it's suicide. I was going to say, but it's about suicide prevention primarily, because you get to the roots. Now, and there's a good possibility that you will be involved with the U.S. Department of Defense, you were telling me. The DOD, Department of Defense, on suicide, and I'm guessing it's suicide and our troops, because they come back and they feel suicidal, they feel they have PTSD, they have all kinds of conditions. So you're going to be working on some stress models, I'm guessing. So
exactly. Thank you for mentioning that. First of all, I love your book, and it's a pleasure to be next to another author. But my book is not mainstream reading, as you know. It's called Suicide, and it's about how to prevent it. And as you know, I've done work with the state on my own, lecturing around the country. I've developed a form how to assess suicide risk. I've written articles on that topic as well. And essentially, the book is available. It's extensive, and I've been branching out, trying to hit high-risk groups. And one of them is the military. As you know, they come back very suicidal. There's been an epidemic, practically.
Okay, let's take a little break. Hi there. We have a question on. We had a little technical difficulty. We have a question about what can be done about stresses coming back from some of the war zones, and how veterans can be better treated. So
thank you, Joe. That's a great question, because I've been trying to branch out my work on suicide prevention, and I've reached out to the military, and I'm hoping to present my work at the Department of Defense /VA Suicide Prevention Conference in Washington, D.C. next year. I'm going to use the material I developed here in Nevada, and hopefully use it to build skills for triaging high-risk patients coming back. I see them in where I work all the time. See, as you know, suicide's an epidemic now in military personnel returning, and I'm working on treatment options for extremely high-risk suicidal vets, including a vaccination, perhaps. So, anyway, that's research and theory, but more aggressive work is needed to decrease suicide. So, by educating nurses in the military who see these high-risk patients, I hope to help next year.
And I do, Mark, I do a group called Post-Traumatic Stress Disorder group. It's a trauma-informed care group on the unit, where we talk about some of the factors involved in, and dual diagnosis is another one, co-occurring type disorders, and a lot of vets have the co-occurring stuff going on too. So maybe, I don't know, that all this stuff folds together because veterans have
well, they have a high risk of co-occurring substance misuse. And another area of interest I have is the methamphetamine epidemic and how that affects suicide and mental illness. And I'm trying to come up with treatment guidelines and treatment options for suicidal meth patients. It's very hard to get that material published in mainstream psychiatric journals now, but I'm doing some cutting-edge work like they're doing at UCLA. Bupropion for depression, doxepin for anxiety in meth patients. There's promising work with Lamictal for the meth tweaking. And it's very important to not discriminate against mentally ill patients who do substances. That should be expected in our patients, and we should treat them even more aggressively. And if you do and interrupt that cycle of substance abuse, medical problems, and mental illness, the outcome could be very nice.
Improved much, yeah. And I know that I did an interview with former First Lady, I don't know whether she's still first, Dawn Gibbons, and she took on the war on meth kind of herself, and during that time Jim was still involved in that kind of thing, and I saw her, she brought out studies that showed that 17% of the high school kids had used meth. So it's like an astounding number. So it really dumbfounds me that the Journal of Psychiatric Medicine would not accept that kind of thing.
Well, it's very tricky, and depression is very underappreciated in meth patients, and meth damages the depression circuit. So it's extremely hard to treat. Psychosis tends to be overrated, but the worst thing is suicide. The method of suicide becomes very violent and lethal when meth is involved, such as murder, suicide, hanging, stabbing. These become the most common methods in meth patients, whereas patients who don't do meth, it's more common to overdose or cut your wrist. So it has a profound effect on suicide, and I hope the politicians here are supporting this work. I'm glad Ms. Gibbons did that. I know Dean Heller personally wrote me a letter thanking me for my work I've been doing with these patients. So it is still an epidemic, and it's contributing a lot to serious problems. And there's new cutting-edge treatments that I want to let you know about that should be looked into if you have a loved one suffering from that.
Yeah. Is there what kinds of things are you inferring?
Well, for example, if someone's depressed and uses meth, why don't you just take Wellbutrin instead? It's chemically similar. It's safe, prescribed by a doctor. It helps the depression, and won't hurt.
And then there's an SR Wellbutrin too, which is released. So you get it into your system in a more...
Yes, and there's also an immediate release, which meth patients tend to like because you get more of a jolt. And this research is being done right now at UCLA. They're taking patients in their clinical trial for that medicine. And I'm using a little bit of low-dose doxepin for anxiety because that has to be treated in suicidal meth patients. But it's very hard to treat because you don't want to use another dangerous substance like Xanax or Valium. So you have to get creative. So I'm using a very low-dose doxepin that goes right to the depression circuit that's been damaged from the meth. So I really encourage the mental health court patients, the patients that are really debilitated by the substance abuse, to come and see someone like myself who wants to treat and help patients like that.
Because I get a lot of the dual diagnosed co-occurring types in the observation unit too, and they seem to be some of them are so cognitively disturbed that they barely, they're...
Well, some substances, like huffing chemicals, it's tragic to see a 19-year-old with dementia from huffing paint.
Oh,
so,
God.
yes.
That just destroys brain
yes.
cells.
That's a sign. It shouldn't be discriminated against. You should take that as a cry for help.
Yeah.
I like the self-medication idea, maybe the patient self-medicating with street drugs or alcohol, but I've published, as you know, material suggesting 80% of substance abusers either have a medical problem or a psychiatric problem that's contributing to the substance abuse. So if we can treat that, we could decrease the substance abuse. An excellent example is Risperdal Consta, a long-acting injectable antipsychotic given to a schizophrenic meth homeless patient eating garbage out of the trash can. You give them a long-acting good medicine for the first time in their life, they're free of psychosis, and they'll stop doing the meth. They'll want to get involved in getting some temporary housing and help. And it's just so refreshing to see that kind of outcome. Perhaps the easiest one is drinking for mania. It's better to take lithium properly by a doctor for mania than to self-medicate with alcohol, which will kill you physically. So, yes, please come and get assessed if any of those things are happening to you or your loved ones.
Because there is help.
Yes.
Well, I don't know how we're doing time-wise, but I don't know. I'm taking aripiprazole for my moods, and yet you talked about how on your YouTube about how you like to prescribe a peen and a done, but aripiprazole is a Zol. How does that fit into your cocktail, doctor?
Well, technically, it's there's ziprasidone. There's ziprasidone, risperidone, and paliperidone. Those are dones. Then there's penes, olanzapine, quetiapine, and clozapine. Yeah. But you're asking, what about aripiprazole? It's an azole derivative.
How does it work differently?
It's more like a done.
It's like more like a done.
All right.
Okay.
So, but I'm glad you said for your mood. And as you know, here in Nevada, we did pioneer work in 2003 using atypical antidepressant augmentation to antidepressants for treatment-resistant depression. That was in 2003. We published at our clinic. Now you see on television in 2009 the ads, if your antidepressant isn't working, add Abilify or aripiprazole. So as you see, it's becoming more mainstream and public knowledge. So yes, we tend to be more, develop these treatment options, and they hopefully become used more regularly.
And it really does seem to help because like you were starting to point out, I get the anxiety, which then turns to mood stuff, and if I nip it in the bud in the afternoons, then it brings it gives me a great, a more stable feeling.
There are rational reasons to mix medicine like that for more resistant symptoms. That's another reason why you got to go see your doctor and tell him. Don't be afraid if you're psychotic to admit you're having voices, paranoia, hallucinations while you're telling them you're depressed. Mm-hmm. If you don't tell them the voices part, they'll never treat that and you will not get better as much. So you won't get committed if you're psychotic. As you know, you have to be suicidal, homicidal, or unable to care for yourself. So that's a good point, Joe. You need to go in and report all your symptoms to your doctor. And because there's very nice mixtures that are FDA approved to help more resistant cases.
Mm-hmm. Yeah, and I'm a good example of a good example because I've had to add stuff, but I get to where I flash everybody my name tag and say, look, we get to treat people in the least restrictive and potential least restrictive, and we do it with get the best quality of life possible, and we really try to improve people's lives. And I'm glad you came here. I'm glad you're here because that's what getting people into treatment is all about, talking to your doctor, being honest with your doctor. So I think we're just about, I don't know how we're doing time-wise. We got a couple minutes. Well, let's go on to one more question then. Now tell us about antidepressants. We just got a minute. Mm-hmm. I saw on your YouTube that you said that 7 out of 10 people can be treated very effectively with antidepressants when they have depression.
Yes.
That means most people are going to respond the way we want them to. What do we do? Because I saw your YouTube too. You said no shock treatments. No, what other kinds of therapies do we have for people with depression?
Well, for standard depression, you have your SSRIs like Prozac, Zoloft. Yeah. Then your Wellbutrin, which is an NRI, different mechanism. You can combine those and treat using both meds. Now you have your new SNRIs like duloxetine or Cymbalta and Effexor. Those are very potent. But if all those aren't working, you have to get more creative and add something to them. Now, some people build 2 or 3 antidepressants on one, maybe a stimulant and an SNRI. I tend to shy away from that. I tend to augment or add something else, like a mood stabilizer. Lamictal is very promising for depression. It doesn't respond to an SSRI, for example. A low-dose lithium augmentation has clearly been shown for 50 years to help depression if the antidepressant alone doesn't work. And then you have more creative, aggressive approaches like low-dose atypical antipsychotics, as you see Symbyax, which is olanzapine and fluoxetine.
I hadn't heard of Symbyax, which is olanzapine and fluoxetine, Prozac and then Zyprexa.
Yes,
together.
in one pill.
In one pill.
So there's many different ways to treat depression. 7 out of 10 people should get better. The 3 out of 10 who don't, that's the kind I like to see when the standard treatments have failed. Because that's when you have to come up with some more creative mixtures, and generally they're safe and are effective.
Okay, we've just run out of time, so we'll be back with Mark Feiner. Thanks for being on.
Thank you.
I enjoyed your YouTube. Check out the YouTube. Doctor of Mind MD.
One word.
Doctor of Mind MD all together. So you can see that on your screen at some point. Thanks for being on.